Today we will broadcast some of our daily operations, and we prepared 4 cases. First we start with a normal interlaminar case, then an interlaminar case as a recurrence after open surgery. Then we will have an interlaminar case with bone resection, far sequestrated herniation, and we will end with an extraforaminal herniation. So I think we will have a good overview about the possibilities with this technique. First case is an interlaminar approach, a 5S1. S1 compression on the right side. We expect the herniation directly in the area of the shoulder portion, but we will see what happens when we're inside of the patient. So first of all, we start with the approach. Prone position, the table is a little bit tilted, but we have the patient in anti-lordotic position, and then we see the interlaminar window. And when you compare the interlaminar window to the, einmal rechts-links bitte tauschen, to the X-ray, then you see that the interlaminar window has widened a little bit. So we just mark the middle of the interlaminar window near the midline, not directly in the midline, and that's our entry point for the skin incision. When we do the skin incision, it is useful to cut into the fascia too, so 5 to 6 millimeter skin incision. Then depends a little bit on the fat tissue what you have. Then we change into the lateral C-arm position. So the direction of the dilator is towards the disc space. Then we insert the beveled operation cannula, opening to the medial aspect. Direction to the disc space. So, and the approach is ready. Then we insert the endoscope, and everything is now done under continuous visualization. So first thing what we have to find is the flavum ligament. That's the structure in front of us. We are working with this radiofrequency probe. It's a good tool it's an active flexible one, so you can, by pressing the handle, the curved tip comes out. And it's a tool to coagulate, to preparate, and to palpate. It's kind of index finger in the patient for you. So we have the flavum ligament just in front of us. That is flavum ligament. Right side is cranial, left side is caudal, 12 o'clock is medial, and 6 o'clock is lateral. So now we open the flavum ligament as medial as possible. So we pull the flavum ligament tight to the lateral aspect. That makes it much more easier to cut into the flavum ligament. We work forwards and backwards. And always use the radio frequency tool to clean your visualization, to resect all these tiny structures here. So now you see that the color is changing here. It's a sign that we reach the last tissue layer. Yeah, see the different color here. That's the last tissue layer. And now we open the flavum ligament, slight rotation, and then we have opened the flavum ligament. We see the epidural fat here. So we check the erection. And now we prepare the flavum ligament to the lateral aspect. Here we find the entry into the joint, L5 1. And always use the beveled operation canal as your second instrument. I give you an orientation again. So we started medially to open the flavum ligament. Left side is caudal, right side is cranial. Here we see the joint, that means descending facet, ascending facet. And we open the flavum ligament until we find the medial margin of the ascending facet. Now we have to resect parts of the epidural fat to identify the neurostructures clearly. Elektroschimmer. So here seems to be the beginning of the axilla. That's the beginning of the traversing S1 nerve root here. That's the dura of the chorda equina. We have to make sure that we are working lateral of the new structures. So now we will resect the last tissue layer of flavum ligament here to the medial margin of the ascending facet. We always advise to resect the flavum ligament completely to the lateral aspect. The reason for that is it is much more easier in a case of a recurrence to find a bony edge there than to find 3 or 4 millimeters of floppy remnants of flavum ligament. So what we already can see is here the herniated material directly below the S1 nerve root. Then I'm in dissector. So I medialize the neurostructure and check if there are any adhesions. You can so now I can go in with the cannula and rotate the cannula. So I medialize the S1 nerve root, make sure that you don't squeeze the neurostructure. And then the pathology is just in front of us and we can resect it. Yeah, halten. And so I have to remove the whole scope because the sequester does not fit through the working channel. A lot of fat tissue here. Okay. We've taken out the sequester, and now we have to take care for the disc space. That's the rest of the ligament here. That's the defect here in the annulus. Entry to the disc space, einmal den rongeur. So 2.5 millimeters is the diameter of the instrument, so we have a defect of about 4 millimeters. And when we have a defect like that, we always go into the disc space and try to remove all free fragments that are left there, especially here in the dorsal part of the disc, you should look for some more free fragments. So then you have the possibility to work with the radio frequency in the disc to shrink the tissue. Then a 4mm rongeur. And you see the S1 nerve root is directly behind my operation cannula. That's the 4mm rongeur. That's the biggest rongeur that fits into the working channel. So it's a good instrument to work inside this space, but not a good instrument to work inside the spinal canal, because you see the instrument takes away a lot of visibility. So now I rotate the instrument and grab in every direction. 3mm bitte. So just here again an overview about the anatomy. Medially we have the starting of the axilla here. That's the S1 nerve root, caudal, cranial, and here lateral, the joint, medial margin of the ascending facet. Here's the disc space, and when we again rotate the cannula, we medialize the structures. We can medialize the cannula until we find the defect where the herniation went through. And here's the entry to the disc space. Okay, so far for the first case. That's a good case to start with, not only your morning, but also when you start with these operations. Look for patients with an interlaminar window that is big enough. And yeah, then this would be a good case to start with.